Hello. Oh, we're on. Good. Welcome. It's one of these stages where I can't see anything, which is probably a good plan, actually. Can't see you. Anyway, Kelly and I have been asked to do a brief welcome and introduction. I'm Mike Barnes, and one of the doctor prescribers now for children. And Kelly can introduce herself in a bit. So welcome. I would like to say great thanks to the two organizing groups, to Drug Science, particularly Mags and her team, doing a great job, and the MedCan Family Foundation, Hannah and her team for organizing this, and of course to the sponsors, Canda. It's Canda, not Can Doctor. I had that lesson this morning. It's a very good app. Where are you, lads? Is that all right? Good. Relief, Curaleaf, and crystallized nectar. Thank you for sponsoring, and welcome to you all. I'm not going to bore you with too long, just a couple of words. I think last year was the first one, Mags, wasn't it? Yeah, second one. And this is really important because, I mean, all medicine should be patient-focused. Is all medicine patient-focused? Probably not. Well, definitely not. But cannabis, of all medicines, needs to be very much focused on the individual because it's a very personalized medicine. And the industry is trying. In some areas it's succeeded, in some areas it's not succeeding. But meetings like this really help the patients to have a voice to industry, to get their own act together. And it's so important that the patients, and now there's 32,000 of you in the country, not here today, but 32,000 of you in the country. It's a lot of people. We need to make perhaps more difference than we have done so far. And I think, we'll hear during the course of the day, but I think there's 2 or 3 priorities that I have. One is to make the country aware that medical cannabis is available. There's several studies that have shown that varying numbers, 60 to 80% of the population, let's say 3/4 of the population, do not still know that medical cannabis is available on prescription. And that's an extraordinary statistic. For those of us in the field, it's almost unbelievable. And that's one priority, is to get the message out there, because there's a lot of people who could benefit. We always quote about 1.8 million people using cannabis illegally for medical purposes, but it's a far bigger number than that of people who don't use it illegally, but would benefit from it. You can make up that number, but I would guess it's another 2 million on top of that, at least. We're looking at, let's be conservative and say 3 million people in this country would benefit, and there's now 30,000. I can't do the arithmetic on my head, but I think that's 1%. Is it? Even 0.1%, I can't work that out. Anyway, it's a small proportion, and that's the key to me, is to get awareness much higher up the agenda of the public and the agenda of the doctors. The other priority, I think, is to get GPs able to initiate prescription. For those that don't know, GPs can prescribe, but only as follow-up after the specialist is initiated. That was wrong, I think, because a lot of cannabis medicine is GP medicine, if you like. Pain, anxiety, stress, sleep are GP issues. And there's not many specialists who would really need to prescribe it, except obvious things like the children with epilepsy, for example. So getting the knowledge out there, 1, getting GPs to be able to prescribe, 2, get the funding pathway clearer, because I'm sure when Parliament voted to change the law, they didn't vote for it to be only available in the private sector. The will of Parliament is being thwarted because there's only still 5 people prescribed on the National Health Service and paid for by the National Health Service out of 32,000. And that's wrong, and that's not the will of Parliament, and we need to change that. And I think last year I said something along the lines, but I'll say it again. There's 32,000 people. Go back to your GP, to your specialist, and say, look, I'm on this stuff, and it's working. It's helping me. And you didn't let me get it on the NHS. I want it on the NHS. And be firmer. There's too many people who bow down before the doctors, which is wrong. Doctors are not gods. a few exceptions. But yeah, professors, you've got to take notice of them, but not your ordinary doctors. You need to be firmer. And I don't think I did this last year. I'll give the example of my mother. And you wonder what on earth's coming now, don't you? But my sister was very learning disabled with severe epilepsy, and it was in the 50s, early 60s, when there was no respite. You either stayed at home or you went to an institution, that was it. And my mother, who was a strong-minded woman, shall we say, went to the local mayor's office with press. She was ahead of her time, and said to the mayor, I think was quite shocked by it all, I'm not leaving this office till you provide me some respite. She didn't superglue herself to the mayor's desk, as she might do these days, but she sat there and she got respite. So I'm not suggesting that you go to your GP's surgery and superglue yourself to his chair, or her chair, but I think there's strength in 32,000 people who've benefited this medicine. And please go out and be firmer about saying, I want this, it helps me, and I want it on the NHS. The law allows it, so blooming well, get off your backside and do something about it. That's what needs to happen, and I hope days like this stimulate people to be a bit more active in trying to change the system to allow everyone who needs it to have access to cannabis on the National Health Service, which is what is needed. On that note, I was meant to just make an introduction, wasn't I? But I've drifted off. Welcome. Thank you for being here. I do hope you enjoy the day. It looks a great program. I think the film at lunchtime is going to be really good. And I hope you really much enjoy the day. And I'll pass over to Callie, who's meant to be getting a word in edgeways. Thank you.
Thank you. Well, thank you to Professor Mike Barnes. These are large shoes to fill, and thank you everybody who is here. It's great to see loads of familiar faces in this audience and new faces, which is even more encouraging that we are getting new faces coming forwards. Now, as Mike said, we need to be talking about this. So go out there, talk to your GPs, talk to any healthcare professional about the fact you're using cannabis, but also talk to teachers, also talk to those that are out in the general public, because it's not just the healthcare professional stigma we've got to get rid of. It's the stigma attached with cannabis as a whole with society. Now, today marks 5 days, and Medical Cannabis Awareness Week was first set up by an organisation called PLE. And unfortunately, a little bit of sad news, one of the founders of that, Maddie Smith, is no longer with us and has passed to the other side. So I'd just like to take a moment of silence just to remember the great work that she did and be thankful that we're all here today. On a more cheerier note, we've got some fantastic talks today from patients, doctors, people from industry, and feel free to ask the questions surrounding that. Without the patients, there wouldn't be an industry, and that is what today's conference is about. And with all the turmoil that we've got going off around the world, where we've obviously got conflict in Gaza, we've got conflict in this country. How I want to remember this actual conference today is to just remember the great words of Bill and Ted. Be excellent to one another. Have a great conference, and I hope we all make new friends today. And let's get the first panel on and get this thing going.
For patients who have been prescribed cannabis, the benefits have been life-changing.
That's the big difference for us that cannabis gives my son. It gives him that quality of life. He's learning, he's using eye gaze, he's making choices using switches, using talking tiles to try and communicate. He said one of the carers' names the other day, just out of the blue, just said it. He's doing everything that he wants to do and progressing basically in life.
Before medical cannabis, I would never leave the house. Within 3 days, I wanted to go out, and I asked my girlfriend if we could go somewhere. I think she was a bit shocked.
It's difficult to access a cannabis prescription. There are a lot of obstacles. Some doctors are obstructive. Some lack training. The NHS hardly ever prescribes it. Private prescriptions are costly. Pricing, supply and quality vary.
If I can't afford it, my seizures will, I presume, start again straight away. And then I'll lose my son if I'm too ill to care for him. And then that's my life gone.
I spend a lot of money with a private clinic. Despite that, the service is often terrible. Prescriptions go missing. My normal strain goes out of stock. And then they ring you up last minute with changes to the product, and therefore the price.
It's difficult for patients taking cannabis in a context where it remains criminalised and stigmatised. People confuse legal and illegal cannabis. So it's hard to talk about your medicine with family and friends, or your employer, your landlord, or even strangers. It's hard to take your medicine in public places. Police, security and customs officials need training.
If I'm going somewhere new, I try to research it beforehand. I even have a look on Google Maps, see if there's anywhere a bit discreet to vape my medication. I'd rather put myself out and have somebody confront me.
It's a big added stress on top of being so ill.
Thank you all for joining us for the first panel today. Thank you for that great video. Mike was right, it's pretty blinding up here actually. Yeah, thank you for joining us today, and thank you to Mags and Sarah and Matt and the rest of the team for the brilliant organisation, this great venue. Got a good day ahead of us. My name is Anush Desai. I am a lawyer and host of a long-running podcast called The Cannabis Conversation. We've got a great panel here to talk about a great topic, which is cannabis innovation, different ways of improving cannabis consumption from new formulations to devices. I will begin by introducing the panel. We have David Martinez, who is CEO of Blackpoint Biotech. We have Becca Allen-Tapp, who is patient extraction equipment consultant and founder of a global women's network. That's a bit of a mouthful. And we have Tim Kneen, who is Chief Strategy Officer for 113 Botanicals. And finally, we have Jess Edwards, who is gardener and mother of a pediatric cancer patient. Really great lineup, lots of different views and knowledge to be heard here. We haven't got a huge amount of time, so let's kick off with each of you. If you don't mind just briefly introducing yourself and give a bit about your background and relationship to cannabis.
Yep. Thank you very much, Anuj. As you mentioned, I'm the CEO of Blackpoint Biotech. So our company we're focused on delivering cannabinoids in a different way, using metered dose devices, which are rapid onset. And I think that one of the biggest issues facing the industry is the inherent problems around dosing with flower and the inability to deliver an accurate and repeatable dose every single time, right? So if we want this industry to get to where we would all like to get to, I think we need to broaden the kind of products that are out in the market. So that's what we're focused on doing.
Thank you. Becca?
You've already done a lot of the work for me, so thanks.
Please elaborate.
Yeah, so to summarize it, I came from the recreational market in the US. My experience is in laboratory equipment distribution, so I help design and build facilities. I've recently moved more into a consulting position so I can branch out and do my own work. And now I live over in the UK. And I'm also a patient, so I'm sure we'll move into that later though. So.
Well, hi, good morning everyone. My name's Kneen. I'm Chief Strategy Officer with 113 Botanicals, and we're a science-based technology organisation. We're targeting some groundbreaking research to address exactly this point of delivery. You know, I've spent 30 years in the pharmaceutical industry before joining 113 Botanicals, and our passion is about finding new innovation that can help provide access to what this compound can deliver. It's not easy to get it into the body, and so we all appreciate the challenges associated with that, and so we've got a great partnership with the University of Sussex, and we're pulling together some great insight and intellect in order to find new ways that can really address that unmet medical need.
Morning, I'm Jessica. I'm James's mum, and my husband and I grew cannabis to help our son when he was diagnosed with a brain tumour when he was 2. He was given just a few months to live, and we were told to not look anywhere else, to not research, not to look online, just to make memories and enjoy the time that we had. But when you're a parent, that's very hard to sit back and do nothing. So you do go and research, and we bought seeds and germinated them, and we bought tents and lights, and we grew amazing plants. And we gave it to our son. It was scary, but when you've got nothing to lose, when you've got no other hope, that's what you do, don't you? You just do whatever you can. And he thrived. He thrived on the cannabis for a long time. He died in 21, so 2.5 years ago. So he was 6 when he died. So he was 2 when he was diagnosed, and lived a lot longer than he was supposed to. So.
Thank you, Jess. We'll talk a bit more about this in a minute. And thank you all for introducing yourself. So we're here to talk about innovation, and in the UK there's a heavy emphasis on flower and oils as the main formats for cannabis. But could we open access further and broaden the patient population if we provided more options of ways to take cannabis? So that's what we'll discuss now. And we'll also have some questions at the end, so please keep those warm for when we throw it to the crowd. Let's start with the patient perspective. So Becca, if you don't mind kicking off for us, what do you think of the current offering in the market, and what would you like to see? And obviously with the benefit of your US experience as well.
Of course. So first off, I'm thankful there is a product on the market and that we are able to have medical cannabis available, and a lot of that is due to the hard work of some people in this room. So first off, let me say thank you. Is there room for improvement? Of course, there always is. And it's kind of serendipitous that I'm on stage speaking about this particular question right now, because yesterday I couldn't talk because my lung was so inflamed because, like I mentioned, I had cancer. It resulted in the removal of my left lung in 2019. So if you hear me a little out of breath, it's because it's still a little sore today. So I get reoccurring pleurisy. If any of you've ever had pneumonia, it'll feel like you've had the wind knocked out of you. It hurts to breathe. You use very shallow breath. Maybe you've had COVID and had that affect you. So I use cannabis edibles to help me with that pain because I can't vape, and that's a lot of what's on the market. Topicals aren't going to hit that pain threshold. So I really feel like we need to stop looking at edibles as a recreational product only, lean into the science behind nanoparticles and how they can be accurately dosed, and explore those as an option for an alternative to flower and oil inhalation. So that's really one area that I think has been underrepresented and really kind of demonized.
Yeah, it's really useful to bring that up, and we'll talk about the importance of dosing in a bit as well. And are you seeing anything around devices as well, or is it mainly kind of format in terms of edibles, as you were saying?
I'm sorry, what was that?
So devices to help with consumption.
I mean, yes, there are some devices I think that are on the market that are helpful for consumption, but most of them are for inhalation. You know, that's kind of where the focus has been, it's inhalation, and there's a hugely underserved population that has, you know, issues with that they have with their heart and with their lung. And so I feel like the only option on the market right now is what are oils, like tinctures.
Yep.
Which, even though sublingual is supposed to kick in 15 minutes, let me tell you that that's not always the case. There are times when I have it, I'm like, okay, it's been 90 minutes and I haven't felt anything yet. So I think that we just need to continue to expand on the product availability to match the needs of each person's endocannabinoid system.
Yeah. Yeah, I think that's a really useful point, actually, to there is much more than just inhalation. And actually, this is probably a kind of good point for you, Jess, as well. How do you feel about this from a carer perspective, and especially when it comes to kids? There are obviously obvious things that you can't do.
Well, the last thing you need is more stress. So, you know, trying to bribe a 2-year-old to take something that really does taste, I mean, I'm sure most of you know it doesn't taste very nice. It's really, and that's a big problem with it. I think he could sense that the desperation in my eyes, really, and he was very good at, you know, I could reason with him. He was very intelligent, and and I could talk him into it, but the bribing and the begging, it's just so stressful, and then you tarnish other foods. You know, if you try to disguise it, then you create negative associations with things that they do like. So if you're trying to put it into a bit of orange juice or a bit of, you know, something, or some honey, then those things become horrible, because he's not, you know, he wasn't stupid. He could taste, you know, that things just didn't taste right. So that doesn't work. It's got to be a medicine. And but there were also things like, you know, a chocolate button afterwards. Trying to get him to hold the oil under his tongue for several minutes was challenging, but I did manage to get him to do it for sort of like 3 or 4 minutes. And the problem was when, well, because he was so well, he started school and he was just like a normal child, was learning to ride a bike, going to swimming lessons, and so then, of course, we lowered the dose, because we thought, well, he's fine. He'd had stable scans for, you know, 2 years, and the oncologist said, well, maybe it's just scar tissue. The tumour looks sort of dormant. So we don't know whether, we didn't know what we were doing. You know, we were just winging it. We couldn't talk to anyone. We were just in this sort of secret world doing a secret drug trial, and so we lowered the dose, but he was also growing, so he probably shouldn't have been having a lower dose because he was much bigger. During the first school closure in the first lockdown, he started becoming unwell again, and then we really put the dose up a lot, and he wasn't obviously at school. But the tumour was then so aggressive, and he had a tumour called DIPG on the brainstem, very, very aggressive tumour. And you know, we don't know why. The doctors just said he was an outlier. Obviously, we believe that it was the cannabis, because it just seemed to be that, you know, he sailed through radiotherapy, and the doctors he was supposed to be neutropenic. He was supposed to have all these side effects from the radiotherapy, and he didn't have them, and he was just so well. So we can't explain it, and that's why we need more research. We don't know what happened. But getting back to the dosage, the swallowing of it. So when the tumour became much more aggressive, it took away his use of his tongue. He couldn't swallow. So then we couldn't get him to hold it under his tongue, and he was having lots of steroids and morphine, which were very sickly, sweet. And at that stage, if I could have just had it, if we could have had it medically administered, you know, I think the side effects of the steroids are so awful. He went from being just such a sort of sweet, sensitive soul to just being angry and miserable, and he would just sort of throw his cup at me, and he just wasn't James. So I couldn't get him to take the cannabis anymore. And I think that's when it would have been so crucial to really help with those side effects of the steroids.
Yeah. I mean, that's really interesting. The first 2 points there, the most common association is inhalation, and we've both heard 2 very good reasons why we need to expand that. And I you know, for scientific reasons, I'm sure there's major challenges with intravenous delivery, but you know, if it's an end goal that we'd like to, particularly for children, it would be great to get there. So thank you, Jess. Tim, maybe let's switch to you now. What are you guys up to in terms of formulations and trying to find different ways?
Just listening to both those stories just absolutely brings it home as to what we're doing. Is that me or is that you?
Could be, yeah.
I don't know. Hopefully, I'll keep without whistling. But it brings it home that the importance of the work that organisations like 113 Botanicals were going through, because it's finding innovative ways to deliver what we know is a highly effective compound, but that can be delivered as a medicine and delivered to all patient types. So our whole focus was thinking of how can we innovate in this space to take a medical approach to delivery of this amazingly effective compound. So 2 elements to that is that the patients can benefit from the delivery mechanism, and you know, critically, that the physicians have a familiarity with what this medicine does, because the reality is that we've still got such a tiny population of physicians that can support patients as they go through whatever that journey is, because that complete lack of familiarity and uncertainty that's associated with delivering things via oil or via vaping, is that to encourage physicians to take that step is clearly very difficult. So what we were working on, we're a UK-based organisation. We've been operating for 3 years. We've now built a production facility down in the south coast, down in Worthing. We've got some great technology in terms of extraction, but it's about the delivery mechanisms that we work on, this biological process of delivering cannabis. So we're very close to bringing a first product in, which is a true controlled sustained release product. So it's a capsule that then a patient can take. Cannabis, as we said, as we all appreciate, is a difficult product to get into the body. You need to get it past the stomach, and then it's only absorbed in the small intestine. So you've got to have the right technology to enable that to happen. So then, once it gets into the small intestine, to be able to manage most of the chronic conditions that we all understand, you want to have a consistent, sustained release profile, which is, when it comes to sustained release products like cannabis is, that have the same profile, you want that linearly over time, so you can deliver the compound over 12 hours. So you get 1 capsule in the morning, 1 capsule in the evening, gives you that controlled, sustained release. So you're not having to, I need relief now. This gives you that coverage over time. So that's what we've worked upon. We're really close to being able to bring that and make that available to patients. We're working very closely with the MHRA. They're very positive and supportive in our commitment is to work as quickly as we can to bring the product and make it available as the first product we bring to market, but also to address that challenge that exists where clinical data studies, we hope to have a product that fits perfectly into doing a whole clinical program of data generation to address that gap of knowledge and insight. What does cannabis do? We're doing some really interesting studies, how it works on a cellular basis. So addressing all those questions. We know it works, but why and how, and what does that look like? So we're tremendously excited. 2024 is a big year for us as we look to then make product available initially UK and then into Europe and across the rest of the world, because just every time that we speak to anyone, it's clear there's a huge need. The last thing I'd say is that to address that other element of what do you do if someone can't swallow a pill? You've got to have other innovation that can support that. And cannabis, again, difficult to get. It's difficult to get in through the skin. It's great sublingually, but it's not easy with oils, taste, everything else that we all appreciate, especially with kids. So the next innovation, which we're really close behind that, is patch technology. The patches that we measure everything that's available on the market. Cannabis is it's difficult. It's lipophilic. It's difficult to get. That means it's difficult to get through the skin. So we've got this great innovation that's been developed in patch technology that helps to really deliver it in that same controlled fashion, which is pretty close behind the capsule to come to market. So only to give a flavour as to where our whole focus is to try and find new solutions to provide in a medical controlled, secure, safe dose format this product to a whole raft of different patients. So we're excited, and we look forward to next year and that development of the product, and then the clinical program that we'll bring alongside that as well.
Cool, thank you, Tim. Yeah, patches is a very interesting area as well. David, maybe we could move on to sort of more the product side of things and what you're doing, and actually maybe you can talk a bit about the importance of consistent dosing.
Yeah, I mean, it was great listening to Tim speak, because I think the approach that they're taking is very much the same as the one that we're taking, albeit very different products. But the whole ethos is let's broaden the market with different products, different delivery methods, which I think is critical. I think it's really, really essential. If we look at where the industry is now, or the barriers that are stopping more doctors and more patients getting on prescribed cannabis, the doctor is critical. The doctor is the one that holds the pen to cannabis prescriptions, right? I think us, and similar to Tim, with what we're doing with Blackpoint, we're not trying to reinvent the wheel here. We're trying to. So our company, Blackpoint, as I mentioned earlier, we focus on metered dose devices. We use the same technology as Ventolin or asthma inhalers, and we remove the steroid, we reformulate in a different way with different excipients and put cannabis in there to deliver an accurate and repeatable dose of cannabis every single time. The benefit of that, or at least we think, and some doctors have agreed with us, is that they understand the delivery method, they understand the route of administration, which if we want to really gain traction in the cannabis space, we need products like what Tim's doing, we need products like what we're doing, making the products familiar with doctors so that they can have the confidence to be able to prescribe. I think as well that one of the largest issues in the cannabis space is, as I mentioned earlier, the inability to deliver an accurate and repeatable dose. And that dose to be a small dose, not 20 milligrams, 50 milligrams when you consume flower, and it's very difficult to gauge exactly how much you're consuming. Flower degrades over time, so even if your COA says it's 20%, could end up being 16% by the time that you consume it, right? So those are the challenges which I think Tim and I are trying to resolve. By delivering a low dose, you essentially put the control back into the hands of the patient and the doctor. Negative side effects can be reduced significantly, and all of these things are starting to play their part to break down the barriers.
Yeah, really interesting angle. Becca, do you want
Can I add to that?
Yeah, please.
Okay, so I totally agree. It needs to come from the doctors, right? But like, I really am a fan of the two-pronged approach because I think that getting the patients to start talking about it, like what Mike Barnes was saying earlier, is like if we walk in and talk to our doctors and we start to get it in their minds, like we need other options, this is what's working, I think that it might help actually like speed up the process too, because at the end of the day, like the patients are the consumers. So targeting them as well to start talking about it.
I think it's really interesting.
I was just at that point, you look at all the data, the analysis is that within the UK population, you've got kind of half the population of doctors recognise that there are benefits to cannabis treatment. It's a fraction of those guys that will, those individual physicians that will then say they will prescribe it. So even though they know the benefits there, there's still a tiny fraction of that population that will feel comfortable to prescribe it. So we need patient lobby for sure. We need clear evidence data for the physicians to feel comfortable with that. Because what we're asking the physicians, if I look at it through the physician's eyes, what we're asking the physicians to do is to prescribe a product through the specials process. And that's a different decision-making process than what the doctors are used to.
Sorry, Tim, could you lean forward to your mic, please? Just a little bit while you're talking. Sorry, man.
I was just speaking.
I don't know if you heard anything I said then.
It was really good.
Oh, thank you. I was in the process of saying that for the doctor to prescribe a product in this field, it's a different decision-making process that we've got to ask them to do, because they're prescribing the product through the specials route. It's great that we've got that access, but they need to feel comfortable. The doctor's making that decision to prescribe and taking the responsibility themselves. And so increasing that familiarity that we've just talked about, that security, the safety, the dose is precise and measured, that then, and the data that is there to support it, that then gives that security to the physicians that we would hope then we can, with that two-pronged approach between patients and physicians and data and the influencing bodies and NICE and everyone else, can then ensure that we can see the utility of this compound, which we know makes a massive difference to patients.
Yeah, and Jess, I'm going to come to you in a sec, actually. There seems to be a kind of inherent tension here, because if doctors are, let's say, the gatekeepers, in a very simplified version of this, having things that they're more familiar with, I mean, flour is not something they would be familiar with prescribing, is hopefully going to make them feel more comfortable about prescribing, but might also increase the patient population. My mum, for example, might take a pill that was prescribed by her doctor, would not want to know what to do with some flour. Jess, when you were, the doctors that you were dealing with, what was their general kind of perspective on this?
So we did ask the oncologist about cannabis, and he may as well have laughed, really. I mean, he just sort of, it was very, he just had a very mocking tone about it. Just said, you know, there is no evidence, that, you know, there's nothing. I did go and search, and I found a private clinician in London. I think it was a Harley Street cannabis clinician, and he charged me £225 for a 20-minute conversation, in which he told me that what we were growing was useless, wouldn't help him. We had to pay him £1,200 for 70 doses. And I said, why would something we're growing, you know, something natural, not work, and something synthetic, you know? And he just said, well, that's science, you know, I can't explain that, that's science. He said, let me put you onto my, you know, dispensary, and also, while we're at it, I really recommend you buy our Simprove probiotic drink because, you know, did James, asking me about James's stomach, did he have a poorly stomach as a child? Which he did. He did have stomach problems, and so he was sort of telling me that, you know, a low gut microbiome was, you know, could be potentially a cause of cancer. So it wasn't a great conversation. And so then I did track down a guy in Spain and spent more money on a Zoom call and he was really helpful. He told me that we had to do a week's break to re-engage the cannabinoid receptors. So he'd been on it all the time, and he said, no, you need to get to week 5, reduce the dose for a week, and then give him a week off. And in that week, give him CBD, so that he's, and he also said that we should give him CBD all the time as well, because he said that the THC and the CBD worked well together. So then that's what we started doing. We started giving him this sort of 6-week cycle of having a week's break. He was really well for a long time. So, but just going back to the taste of things, you know, the problem with pediatric medicine is that it's all so sickly. If you look at the ingredients on morphine and the steroid, there's 5 E numbers in each one. Now, my son had the most horrific night terrors you've ever seen on these medicines. The night terrors were more traumatizing than anything, actually. Just so awful. And, you know, they dress things up, they sugarcoat things, and, you know, so how could I get him to take my medicine when what he was having was just like syrup? So I don't think that by adding all these E numbers to things, it's just, that didn't do his brain any good. Those night terrors were, you know.
Yeah.
Sorry if I'm
no.
off topic.
I mean, there's an acceptance of, you know, pharmaceutical drugs that have loads of side effects and terrible things in them, but they've passed a certain barrier.
Yeah.
They're happy to prescribe
Definitely.
them, which is always a difficult thing.
Yeah, after James, sorry, just quickly, after James died, the oncologist telephoned me from Bristol and to offer condolences. And, you know, for 3 years, I'd been just dying to tell him. You know, we'd sit in his office with James playing, and he was so well, and he'd just be saying, God, you know, he's just doing amazing. And we just found it so hard lying. I desperately wanted to tell him, but we just couldn't. We were so afraid that we would have social services come and take our plants away. And so when he phoned to offer condolences, then I said, you know, I just want you to know this is what we did. And he just made nothing of it. He just said, yes, we're aware that parents do this kind of thing and don't tell us. And yeah, we're very much aware of that. And that was it. So.
Thank you, Jess. Thank you. We're going to throw it open to the crowd in a second. Just a quick question before we do that. There's a big belief in whole plant and full spectrum solutions in this space, and the more pharmaceutical approach is sort of single compound. How do we kind of bridge that gap here when we're talking about innovation, and both from a device and formulation perspective?
I think we'd certainly, a big part of what we do, if I lean forward, a big part of what we do is the extraction process. There we go, I can hear me now. There's the extraction process itself, and is to make sure then that when we go through the process of taking the active compound, is we're doing as little as we can to keep it as active as it needs to be, and then being able to put that in some kind of delivery mechanism, which will make it go to where it needs to go in a consistent, measurable, safe and low dose, and that's exactly our focus in that context, either through capsule technology or through patch technology, whatever way we can, to make sure it's predictable and safe.
Yeah, brilliant. Thank you, Becca.
Okay, I'm going to jump in real fast and say that I think we also, as consumers of the cannabis, should know what the process is, knowing what a whole plant product is versus an isolate, knowing how it's being done, know what the process of crystallization looks like, what solvents and potential chemicals are in it, because then you can decide what method is best for you as well. A distillate with a high THC and maybe nothing else in it might be good for some people. An isolate might be beneficial for others, and then closer to full spectrum might work for someone else. So it's up to us as a consumer to understand the process behind the method our medicine is given to us as well.
Yeah, I would just like to add the complexity around that whole topic, right? Because I think it's competing principles. Because obviously plants, it's inherently variable, and then you've got the standards to which you need to manufacture products, and the regulators. The principles around GMP manufacturing is repeatability and standardization. So you've got two competing principles there. So it does make it very difficult to be able to combine both of them together. And I think eventually we will get there. But as everyone in the cannabis industry knows, we're only in the first innings. It's still very early days.
Yeah, and ultimately it's transparency, isn't it? As Becca was saying, the more information you have about what is in that product allows you to make a more informed choice. So I will throw it open to the crowd if anyone else has a question.
Anuj, I've got a couple of questions off Zoom.
Should we do one in the room first? Is that all right?
Thank you very much. I'd just like to tell you my story of listening to, obviously, a parent. My wife had very, very aggressive cancer 8 years ago. I did a little bit of research, and I'd heard that maybe cannabis might help. So my wife was on this with me. So we managed to purchase about fair few pounds worth of raw cannabis. And I then took it, and I got my friend to get me 2 litres of ethanol, which was not easy to do. I then crushed it all up in a pestle and mortar and put it in a rice cooker, evaporated off the ethanol, and I was left with a brown goo, which I assume was CBD. There was no YouTube video to tell me how to do this or anything of that nature. But I then gave it to her on a piece of bread, and she didn't like the taste. So taste was obviously an issue. I actually had a little bit once, and it sort of didn't really do a lot, but I did get some fairly high, not high, but my hearing went rather crazy. Anyway, when she sort of had 2 lots of chemo, she lost all desire for taste, and everything tasted horrendous. So what I did, I got some sweet molds, and I got some coconut oil, and I turned it into pessaries, because she used to have pessaries for thrush, caniston, and I then gave her, like the guy said there, 1 in the morning, 1 in the afternoon, in both areas, which because that's where her cancer was. Her cancer was in the womb, or after she'd had her hysterectomy, it went everywhere else. Now, it didn't cure her, clearly, she passed away, but she never went on to morphine. She never went on to aggressively, really high dosage of painkillers. So I can only assume, and I take sort of some comfort in the fact that she died at home and was, compos mentis, etc. So I just wondered if you'd ever thought about doing pessaries, because that, to me, was the best way for me to get the cannabis directly where she had the pain and the problem. So it seems like a pretty obvious option to me.
Thank you. And thank you for sharing the story. It just never fails to amaze me whenever we have these discussions, is the innovation that you have to address, because there's lack of data and lack of immediate solutions. So, we spent a lot of time trying to understand the digestive tract, to think about how best to deliver the medicine, and the rest of the body. Where will you get that ability to deliver the active compound the most effective, easiest way, most effective way, and to do that consistently, deliver it over time. And that's, for us, that's where we've said that the best and most effective way is to use the passage of a capsule through the intestine over time to deliver the dose over time. We were discussing this morning, suppositories in certain parts of Europe are far more popular. UK suppositories are not very popular. In France, they are exceedingly popular, but the same with pessaries. It's an immediate relief that you're getting. It's not sustained. It's difficult to imagine how you can sustain that over a long period of time, and so. Perhaps it's the combination of different things, but our focus is look at the chronic conditions. This is not just an immediate relief, is that you ideally want to be able to have a consistent delivery of a drug over a long period of time. And so whatever mechanism you can use that can help you to achieve that's the optimum goal.
I do think it was more of a sustained release. We did use the suppository sometimes. When we mixed the oil with, because we, like this gentleman with the rice cooker, and reducing it down and then mixing it with coconut oil, and then we would syringe it into capsules, and then it was like soft butter. Yeah. So you'd keep it in the fridge, take it out, pull the capsule apart, take off little bits. So obviously we started off with tiny, tiny amounts, but we could use the suppository when he was younger, when he was asleep, but obviously when he got older, he wasn't really up for it. But yeah, we did think of those other ways.
Amazing. Yeah, and again, it may be a combination. It's the availability of different solutions for different problems. Thank you, guys, and thank you for sharing that. Anything else from the?
Hi there. I just wondered, there's a big availability of like CBD drinks in the shops. You walk down the road, they're there. Is there any consideration like liquid cannabis, or as we know, like bang lassi, you can put some hash in some milk, make some tea. It goes down quite nicely. It doesn't really have a bad flavor to it. It just seems like quite obvious. And you could just boil it up in water and drink it. Is that not a good dosing?
I mean, this is really interesting, right? This is the consumer market meeting the medical market, guys.
I'm going to jump in on this because, like I said, I came from a recreational market when beverages hit the market. Those are still very hard to dose, really, really hard to dose. The only terrible experience I've ever had was from a beverage that clearly the dosing was just off, or it settled funny, and or I don't know what was happening with it, but I heard voices. So, and it was low dose. So, I would say beverages are going to be something that's going to be a little bit tricky, not impossible. It's going to be a great area for nanotechnology. I would say CBD is probably safer bet than THC. THC drinks are really, really not going to be considered medical, I don't think, because of the variability in the process, because of the taste alone and the methods of refinement that the cannabis would have to go through to be able to blend into a beverage and be able to be accurately dosed. But I do think CBD drinks, there's definitely a space for those. There's already some really good ones on the market, and that's an area that I think needs to be explored.
It's one of the areas that we are having a look at, because we're measured everything that's available at the market to look at the actual release profile and how much gets absorbed where, and there's nothing that delivers a clinically meaningful dose that has to pass through a liquid. At the moment, the technology's not there. And it is one of the areas we're looking at as to how to remove the taste and then make sure it gets past the stomach, so then it can be released. But that's one of the next developments for us.
It's all about those pharmacokinetics, right?
Yeah, it is.
How it's distributed.
In my experience, the problem is when you get it wrong, and then that's where the stigma and the bad reputation comes from, and you have a bad experience, and then you get put off for life. My dad has Parkinson's, and my stepmother made him some cakes once, had too much, felt horrific, ended up going to hospital, and now he's, with his tremor, he will not touch the Parkinson's. And Now, with James, it was so controlled, not once did he have a bad experience on cannabis. We laughed and ate and slept. When your child is suffering and they're when they've had 6 weeks of radiotherapy, he had to have general anaesthetic every morning for 6 weeks. And all the other children around they just looked so poorly. It was, it's the worst place on earth. No one wants to be in a paediatric oncology ward. And then you've got your son sitting there, and the other parents think that he is a sibling of a poorly child because he couldn't possibly be poorly because he's eating and he's laughing and he's sleeping. What more do you want for your child? You want them to be able to eat and sleep and laugh. So cannabis, that stigma has got to be removed. Because
and it's such an important point, isn't it? That get it wrong and there are consequences. And goes to David's original point about consistent dosing and standardization of it.
There are other parents there, that were just too terrified. They just
of course.
Yeah, most people are too afraid.
Just to add to that, I mean, the MHRA's mandate is to reduce risk. And when you have products like edibles, you have a greater chance of something going wrong. And whether you agree with that approach or not, if something goes wrong with an edible, it brings the industry backwards rather than forwards.
Is it like paracetamol or those other things potentially more dangerous though than I think that's such not saying that's but I think that excuse is God, we've got to work back because there's more dangerous stuff under our kitchen dish sink, for children.
But you're working against decades of stigma, so it's almost like you're having to get people to unlearn stuff in order to.
And it goes back to data all the time. Just evidence data, which there isn't enough of, and we've got to work very, very hard to address that gap.
Sure. That's why I said whether you agree with it or not. This is the field that we're in, and we just need to adapt if we want to take this forward.
Yeah, true. A question from Zoom.
We've got a few questions. So one, I think you've already answered before, but I think there's a wider scope to it. Will there be an ingestible product that people who use gastric tubes can use? And also just the general question as to consumption for folks with other disabilities, other conditions, for example, asthma. Vaping is not really an option for them. What kind of products are you working on at the moment that you can talk about?
From our perspective, that's exactly for that kind of patient. I think going through the skin that can't swallow is a really solid, sensible approach. But you got to get the right technology that can support that same control and consistency of delivery. So certainly, what we're very excited with the new innovations that we've got in that space with patch technology, which would help to address that. I think what we would hope is that we're then covering a real broad range of patients that could benefit with their chronic disease in that way.
Your capsules. I mean, as someone with one lung, I'm excited about the idea of capsules.
As long as you can swallow. Definitely. I'm excited to hear that as well.
David, do you want to talk about the inhaler, the asthma angle? Because you've likened your product to a ventilator and asthma.
Yeah, I mean, we use the same technology. So if you just picture an asthma inhaler, our product is pretty much the same, but obviously instead of a steroid, we use cannabinoids. There are many conditions, many people that would benefit from that type of product. As I mentioned earlier, it is a rapid onset metered dose device. So if you can imagine someone with epilepsy or any other condition that is about to have an episode, the preparation time, if they don't have any medicine available, this eliminates the need for preparation, which preparation could take 15 minutes, 10 minutes, 5 minutes, whether it's grinding it up, putting it in a vaporizer, or any other type of delivery method that they use. This eliminates that, and they have the rapid onset immediately. So you can already see a certain group of patients that this would benefit them significantly.
You can see that, like the way that asthma is managed is that you have a treatment for chronic, consistent control. Then when you have a breakthrough, that's when, so that kind of combination, it could be highly effective.
And just to add to that as well, a lot of people think, or a lot of patients may think that they can only use one type of product, and understandable considering the lack of variation that there is at the moment. But as the industry develops, it's like one of my colleagues mentioned, cannabis should be a toolkit. You should have different types of products for different scenarios. A controlled, sustainable release capsule, a rapid onset whenever you need quick relief, a flower if you like consuming flower. So, but that will only come with time and companies pushing that.
And research.
And research.
One more down here. Oh, sorry.
Hiya. I keep hearing lots of talk about low-dose applications for cannabis-based medicinal products. Is there any consideration for patients who are in the high user groups who do need high levels of cannabinoids daily or each dose? Like I've got Crohn's disease, so I take about 300 milligrams twice a day. I get told that I'm an extremely high user and that it's excessive use by some doctors practicing today. So I just wondered, like, how much consideration is there for the high user groups in these kind of like tailored medicines?
I think what we go back to saying what's the bioavailability? How much from the high dose that a patient takes? How much of that is actually getting where you need it to work? And so a lot of the lab work that we're doing is understanding exactly from consumption how much actually gets into the body. And that's when I talk about when we talk and our physicians talk about low dose, it's about getting an active dose at the right level that will produce a defined and measurable clinical impact. And at the moment, we're kind of guessing. And the stories you consistently hear is trying different routes and different delivery mechanisms, and it's a bit of a hit and miss. What we're working on is to get that predictability to understand what's going into the body and what that dose, what that level, in terms of a clinical impact actually makes. And that's when we talk about trying to drive it as low as possible. The lower the dose is that has an impact, you can tick that, and the less potential side effects that come from it. And that's what we mean by low dose. But our premise is to produce a range of doses that have the data to support that for whatever a range of conditions is that we'd be active on.
Can I ask how you're currently consuming? Like what you're currently using? Like what method? Okay. Do you play with other consumption methods too? Because that's kind of like what I've found is that some days I need a really high dose and some days I don't. And it's just I play with different consumption methods based on my needs. But I find that with the lack of variation within products, it's really hard to find that ideal delivery mechanism, because it might be the case that something else would potentially require less, and I think that's like, especially nanotechnology, that's an area that I really think that people who need high dose is going to find more relief, because you'll get more out of the product with less.
Can I just ask, are there sort of strains for nighttime and daytime? Because that was the thing with...
And cannabinoids for nighttime and daytime, for sure.
For James, because for James going to school, that was really tricky.
I can imagine. Sorry, we've got a question over here as well.
Thank you. I'm a German chronic pain patient. Thank you very much. It was very interesting. Becca mentioned twice nanotechnology. And since we're talking about innovation and new formulation, I didn't hear anything about sublingual methods. And also, we're talking about constant THC levels, while Becca was saying, hey, after 90 minutes, I still don't feel anything. What about people with spikes with their chronic pain, or for patients who have an episode of epilepsy or spasm. So we have that a lot in Germany, and they're trying to get new products. Are you also developing products that really reach me within minutes?
So, now, I think I've just figured out someone turns it on and off. I got so caught up talking about the inhaler earlier that I forgot to mention that we also use the same technology to develop a sublingual spray or an oral spray. The benefits to that compared to the other typical sprays is that the bioavailability is higher due to the formulation and the use of a gas as a propellant. So that's the first part. You said that you are in Germany, a patient in Germany. We would love to get our products in Germany to be able to help patients like yourself. Unfortunately, the German regulations as it stands, because they require magistral preparations, which essentially is a pharmacist has to carry out the final manufacturing process. We cannot get our products in at the moment because our products are too close to finished goods. I think Tim's products will probably qualify for magistral preparation in Germany.
Yeah, hopefully so.
Yeah.
It's one of the challenges. Every market that there is, I know we're in the UK now, is some kind of peculiarity in Germany is exactly like that. But we've got a good solution to still make product available to manage those chronic conditions that you talked about.
But you said you need something with quick delivery, right?
Yeah, so the products that we have developed are typically rapid onset.
Sorry.
Sorry.
Mags is threatening to beat me
Mags
up
is telling us to stop talking.
Unless we wrap this up. Thank you all, guys. We could talk about this a lot longer, obviously, and please do feel free to continue the conversation outside. But please, can you put your hands together for